We're going to start with the latest AIH research with Dr. Weinberg. As you know, Dr. Weinberg came from UPenn today to be with us yesterday. And again, I told you all yesterday, he's a true advocate for patients and he loves being a part of these conferences. So again, please join me in welcoming Ethan Weinberg.
All right, good morning, everyone. Thanks for being here early. So my talk is entitled The Latest in AIH Research, and I had a very fun time putting this talk together. So over the past 1 to 2 weeks, I've been looking over all of the research in PubMed. So PubMed is a large repository that's set up by the AIH for any medical study that's been published, and there's a process that the papers have to go through to be vetted to be able to be put on PubMed. And so this is, I don't know, probably between 500 and 1,000 articles over the past 2 years. And what I wanted to do was I went through all of these and focused on studies that have come in the last 2 years, from basically 21 to now. There's one study I put in there from 2020 for specific reasons. But this was this was also a way for me to become updated, not just a few select studies that I'd seen over the past few years, but really be able to see where's the field going, and what are the themes of the research over the past 2 years. And so there were 3 big themes that had come out in looking at what research has been published. And so I broke it up into topics. So the first is on treatment. So what are the updates on treatment from what we've seen in the last few years? The next is what are the updates on liver transplantation in AIH? And then the big one was really COVID. I think COVID and AIH had the most publications over the past 2 years, and that makes sense given that we went through the pandemic and now we're moving out of it into an endemic. And I actually thought the last section I had the most fun was because the speakers we have here at the AIHA conference are really leaders in the field of AIH research in the United States, and so I thought I would highlight one study from each of the members. There is a little bit of bleeding where some of the members had research in some of the other topics, particularly Craig. He hits most of these. So the first topic I want to talk about is treatment. So this is a very busy slide. I don't want you to focus on all of the words. What I want you to look at is what I highlighted. So this is taken directly from the AIH guidelines. So if your doctor is wondering, how do I treat a patient with AIH? This is the first thing that they will go to. And it's an algorithm, and we base it on whether someone has autoimmune hepatitis, if you have with cirrhosis at diagnosis, or if you have acute severe AIH, and I'll go over what that means in the next slide or two. But as you can see, this is actually from 2020, so there's actually 2 studies from 2020. But we use steroids and azathioprine. If cirrhosis is on diagnosis, we still use steroids and azathioprine. It's really when acute severe autoimmune hepatitis is diagnosed that steroids are the first line. And so just keep that in mind. This is sort of, since the last society guidelines, these are our recommendations. So the first study I wanted to highlight was about biochemical response. So biochemical response or CBR, as you'll see it designated here in these slides, means that your ALT and your IgG are normal. So this was a retrospective study, meaning they looked backwards. So patients who were being seen as opposed to signing a consent and then moving forward, that's prospective. So this was done at 7 centers. It's international, 1,700 patients. So it's a very large study. And they followed patients for about 10 years. And what they found was really, and this is something that we intuitively know, but complete biochemical response is really what we're trying to achieve. We're really trying to achieve to make sure, as physicians, to get those numbers normal. And it has a clinical impact. So this bottom slide here shows that if a patient reaches CBR, the likelihood of getting cirrhosis is much lower than the likelihood of is much lower if you have a complete biochemical response. That's this sort of blue area here over 20 years. It's a very low likelihood of developing cirrhosis if you have biochemical response. It also predicts survival. So complete biochemical response, survival is fantastic for a few decades. And this censors out liver transplant. So in the liver world, we use a phrase called transplant-free survival because basically the liver didn't survive, but we're able to perform a transplant so you can continue living. This was about steroid response in severe autoimmune hepatitis. So the definition of severe autoimmune hepatitis is if the INR on admission is greater than 1.4, 1.5 or above, and there's jaundice. And it's what you don't need to know, this is sort of getting into the weeds on this part here, but they developed, this team from Spain developed a scoring system to say, when we see someone for a first presentation, are they going to benefit from steroids or not? And so they came up with this calculator based on a few different clinical components. Do you have encephalopathy? That's the confusion that happens from liver disease. Do you have ascites? That's the liquid that accumulates in the abdomen when the liver has a hard time moving blood through it. The MELD score, and I'll get into that in the next few slides, it's a composite of different lab values. And then the age. And so they made this sort of calculator, or this is a nomogram, and depending on what your score is, it tells us, well, this is the likelihood that you may need a transplant in the next 90 days. And if that likelihood is high, it actually is best to not try steroids. Sometimes we'll use a little bit of steroids or for a short amount of time, but really to start a liver transplant evaluation and start looking for a liver. This also may be, if the score is high, if someone is not at a transplant center at diagnosis, that should be sort of the call to say, yes, we need to transfer someone to a transplant center. This next study is a retrospective study looking at mycophenolate, so that's one of the immunosuppressants that we use, versus azathioprine, which has sort of been the standard for decades. This was a single center study in Greece, and they looked back over patients that had been seen there at their center for 20 years, and they found that patients that were treated with mycophenolate were more likely to have here's that lingo again, CBR. They were more likely to have complete biochemical response, particularly at 12 months versus azathioprine. And there was less non-responders with azathioprine. And they were less likely to change treatment. So patients that had started on azathioprine may have changed treatments during that time. Now, this is a retrospective study, so there's all sorts of biases that are going to be introduced when a study like this is done. But there have been other studies prior to 2021 that have shown similar findings. So the biggest study among sort of physician researchers that's making waves is this one called the Camaro study. And I think I texted Craig when this thing came out, and I said, I feel like this is the sort of thing that makes me think, is this the study that's going to change how we approach first-line treatment? And there's a lot of questions about this. And I don't know that it's going to change treatment yet. Azathioprine still has a large role, and in many patients it works great, and the side effects are little. But this was a randomized prospective open-label trial. So patients came into the study at diagnosis and got prednisone for about 4 weeks, and then at the prednisone taper started either mycophenolate or azathioprine, and it was random. But patients knew what they were getting, so it wasn't what we call blinded. There were 70 patients that were enrolled, and it was about half and half. And what we found, they used a mycophenolate dose up to 1,000 milligrams twice a day, or azathioprine 100 milligrams daily. And the endpoint, what they're looking to see is who developed that CBR, that normal ALT and the normal IgG. And they did find that there were many more patients that were able to reach CBR with MMF, mycophenolate, versus azathioprine in that 6-month time period. So we're waiting. This is an abstract from the meeting in Vienna this summer, and we're waiting on the larger publication to understand. Anytime we look at a trial, we say, okay, that's great. That worked in that patient population. But does that work for my patient? So we want to make sure that, who is represented in this? Now, this is a European multi-center study, so you have to think, someone of European descent, this may work in the United States, but someone that is not of European descent, this data may not apply in the same way. So that's about treatment, and I'm happy to at the end, we'll take questions on sort of any part. But the next was studies on liver transplant, and there were a few that really caught my eye. This was a study released last year on waitlist outcomes. So I have to go a little bit over the jargon first. So UNOS is this large data they're the big organization that is in charge of organ transplants in the United States. Any liver, kidney, heart, lung, pancreas, any of the solid organ transplants are sort of governed by UNOS. And AIH makes up 3.6% of liver transplants in the United States. So it is, that is a small percentage, but that's about, I think, 300 to 400 transplants a year. So that's still a lot of transplants. And the wait list priority for how someone gets a liver transplant, so anyone in this room who has had a liver transplant and is on a waiting list is very familiar, but for those who are not, it's based on something called the MELD score. It stands for Model for End-Stage Liver Disease. And the MELD score at the time was what we call MELD sodium. So it uses the old MELD score uses these 4 factors: bilirubin, INR, creatinine, and sodium. Now, what you'll see is ALT and IgG are not on there. Those are not things that predict mortality in someone with end-stage liver disease. So these are labs that, if you don't have cirrhosis, don't necessarily need to be checked. It's only when a person has end-stage liver disease that these are things that we follow more regularly. So now we actually have updated the MELD score. We now have 6 components to include gender and albumin. We call this MELD 3.0, and it went into effect this past summer. So what did they find? They actually found that if a patient, and this is sort of broad strokes, if a patient with autoimmune hepatitis is on the wait list, from between 2016 and 2019, they were at higher risk of death or deterioration on the wait list. And that's this sort of top line up here. So the higher the line goes, the more likely, or the higher percentage of death and deterioration that happened over a few years. So this is AIH, this sort of line up here. This red line here, this is NASH or MASLD and PSC. And then this is alcohol and I think hepatitis B. And you see, these clearly are separate. So the good news is that this MELD 3.0, it puts in gender and albumin. These diseases at the top are diseases that are sort of women predominant, and these diseases are male predominant. And so what MELD 3.0 does is it sort of shrinks it so that this goes up and this goes down. So the hope is that next time this group looks at this data, we won't be able to, gosh, it will take years. So the MELD 3.0 just went into effect. So we'd have to look at data from 2023 to 2026, and we'd have to have all that data. So I won't be able to share, the good news that this has changed for 7 to 8 years. So, but I think it will, because this is a difference in about 2 points over time, and so this is one of the reasons this sort of gender disparity that we've been seeing in liver transplant. And this new way, it's not a perfect system, the MELD 3.0, but it does a long ways to correct what we're seeing here. So the next one was about recurrent AIH after liver transplant. So this is a big question that my patients ask, and I was happy to see that both Lauren and Craig wrote this paper a few years ago, and they looked at patients with AIH that had been transplanted to their center from 2000 to 2017, 75 patients, and 20 patients had recurrent AIH. And with a patient population this small, and 75 patients with AIH for transplant, that's a very large population for AIH, but for statistical analysis, it's not that big. So there's only a few things that you can see. They have to be really clearly different on who would get recurrent AIH and who doesn't. And they did find some very interesting, they're very interesting findings. The 3 big things that came out of this, and Craig, if I'm wrong, you can correct me because this is your paper, but it's age. The younger age at transplant, the more likely to have recurrent AIH. Race, so black versus, I think in this paper we just used, it was black and white, but black patients had much higher risks of recurrent AIH. And there may be some sort of genotypic and phenotypic differences there that we're still trying to understand. I think Michelle Tana is probably the best person here to explain that, sort of the differences there. An HLA mismatch, and this is really getting in the weeds, but basically if the liver of the recipient and the donor have different immunology genes, that can lead to recurrent AIH more likely. That's the way I look at HLA, and I don't really go any further than that. So this is a paired, I look at this study. This is from France, and this was a larger study over a longer amount of time, also looking at recurrent AIH. Now, this is going to be a different patient population than what we see at Indiana, but they looked at 344 patients with AIH, and they found that it was about the same percentage, near 20% developed recurrent AIH. And what they found was that CMV status, so there's the infection CMV, if someone had been exposed to CMV in the past versus not, and if the recipient had never seen CMV but the donor had, more likely to have rejection. And if you had another autoimmune disease, there was more likely to have rejection. A very small number of patients developed cirrhosis, and they were also able to predict who developed cirrhosis. It was, again, younger age at transplant. Part of this has to do with the years. I'm not showing you the data here, but there was a lot of rejection. So rejection is when the immune system attacks the new liver, and it's not necessarily recurrent AIH, although it can be sometimes difficult to diagnose between the two sometimes. But the longer you have a liver, and this is also an era when the immunosuppressants were very bad. So around 2000, the risk of rejection is much lower. But they found young age of transplant, if your IgG was elevated, and then if a patient had a transplant for acute liver failure, that was more likely to have recurrent AIH. There were a few other studies on liver transplant, but I found that those three were sort of the ones that I found the most compelling. All right, COVID-19. So there was a lot of publications on COVID-19 and AIH, very few that were high quality. Many case reports or case studies. So what does that mean? A case report is one person has one thing and they describe that. A case report is putting a few people together and looking at it, but not in any sort of statistical fashion. And so what I was looking for was, what are those studies that have larger numbers that we can make more conclusions on? So the case reports, there's validity to it, but you want to see, how is this going to change our practice? We want to see it in more than one person. Case reports and also are good to help us understand and keep our antenna up, but they're not necessarily going to change our practice as much as being able to see, yes, these are different populations. So this was a retrospective study looked in Germany, and they wanted to know, are we seeing more AIH diagnoses after the COVID vaccine? And they just looked at their own clinic, and what they found was that they weren't seeing more diagnoses. So 2020, I'll say a lot of people weren't going to see their doctors because we were sort of scared of going outside. But in 2021, a lot of the people had, and this is in Germany where the vast majority of patients had been people in the whole country had been vaccinated. So they still saw fewer newer AIH diagnoses. And what they were a little bit concerned about was the annual clinic visits had gone down during the pandemic. Hopefully this has come back up. So, but this one place that has a lot of patients with AIH, that they weren't seeing an increase of AIH diagnoses. What about the vaccine effectiveness in AIH? So this is a question a lot of patients ask me. And I feel like it's only now, almost 4 years in, that we have more clarity on, with the number of infections and the change in the strains and the vaccines and boosters on top of that. But I think Craig was actually put some data into this large study. This was a huge international study. It's a retrospective registry, and they looked at if someone with AIH had a COVID infection, and then they put the data into this registry. And this is the United States, Turkey, Europe, Greece, like all over. And they had 258 unvaccinated patients and 143 vaccinated patients, and they had to have a PCR positive result in order to get into this study. And what they found was that the vaccine decreased hospitalizations, decreased need for oxygen, decreased ICU admissions, and decreased death. And we saw that if you had even more than just 2 vaccines, that decreased even more. Now, I would say take this with a grain of salt. I think the vaccines are effective. Exactly how effective, I can't tell you whether it's, I mean, it probably is, it's extremely effective, but there's also the change in strains and the number of vaccines people had gotten over time and the acuity of, or sort of the morbidity of the different COVID strains actually has an effect too. But COVID vaccines are highly effective for patients with AIH. So the next thing, I have to take an aside to talk to you about drug-induced liver injury just for probably about 2 minutes, because the next few slides after this, I'm gonna talk about sort of the COVID vaccine and drug-induced liver injury. So this is, drug-induced liver injury is a problem, and it's something that I see in my clinic probably a few patients a week. And this is, we take drugs or herbal supplements or anything like that, and a lot of them are processed through, almost all of them are processed through either through the kidney or the liver. And some of these things can cause liver damage. So the thing that we know causes liver damage in everyone, if you take an excessive amount of it, is acetaminophen or Tylenol. Other ones that can cause it are amoxicillin clavulanic acid, Augmentin. So Augmentin is often used for treatments of ear infections and pneumonia, but this can cause drug-induced liver injury. It happens, I don't know, 1 in 1,000 or 1 in a few thousand, but it happens often enough where, and it has a very classic pattern where it can turn people yellow without necessarily having very high liver enzymes. Now, what I want to highlight though is there's a number of drugs that can cause an AIH-like injury. So it looks like AIH on a biopsy, but there's a clear time point in when a drug was started and sort of we can see that enzymes will come up. And then if we remove that drug, we usually actually have to treat this with immunosuppression for a short amount of time, but it's not lifelong. It's a short amount of time, taper off the immunosuppression, and then as long as we don't restart the offending agent, it doesn't come back. And there are a lot of drugs that do this. Infliximab is one that I see a lot as my gastroenterology colleagues will refer patients to me because they've had infliximab. Minocycline, if people are using that to treat acne. The one we're seeing more and more is immunotherapies for advanced cancers. They really, and this is almost what they're trying to do. They're trying to rev up the immune system, and sometimes they rev up the immune system and it attacks the liver. And so what I have to do, and this is a very hard discussion, is I have to say, we have to stop your cancer therapy and we have to put you on immunosuppression, and we have to wait a long time. These things end in MAB, which means they're monoclonal antibodies that stay in the system for a long time. Statins, I mean, probably tens of millions of people in these United States are on statins, and they save lives, but they can also cause a liver injury. They can cause an elevation in liver enzymes. A lot of times, there's a conversation between a primary care provider and a patient with liver disease, whether they can be on a statin or not. And for the most part, that answer, it's almost always yes, but in rare cases, it can cause a liver injury that we have to be careful of. Now, that's not to say anyone in this room that's on a statin with AIH shouldn't be on the statin. They're great drugs and they save lives. It's just in rare instances, it can cause a liver injury. Isoniazid, this has saved millions of lives across the world for treating tuberculosis, but it can cause liver injury. So we have to watch out for it. And macrobid is a medication we use to treat urinary tract infections. It can also cause autoimmune-like injury. Okay. This is an aside. So I had a patient, one of my patients with AIH, who a few weeks ago told me that she doesn't think she has AIH because she was taking this drug. It was an edible that had this cordalis in it, and there was a report that I'm putting it up in the Colorado Department of Revenue warned about the potential liver injury. But she's been my patient for almost a year, and someone told her about it, and she hadn't told me that she was taking this. And so she stopped it, and her liver is sort of getting better. So just be careful with what you take. Things that, the previous slide, those things have been vetted by the FDA, whereas herbals and supplements, you have to be careful with because you don't always know what's in them, and they can have effects. And a lot of times if I ask a patient, what else are you taking? You don't even think about telling your doctor about the herbal supplements that you may be taking because they can be harming your liver too. So when people say, well, what should I do? I say eat a balanced diet. So that's the diet study that Craig was talking about. Okay, all of that was sort of the warm-up for this. So there are reports of an AIH-like injury that happens after the COVID vaccine. So this was a study in Europe looking at this, and they looked at 59 patients that had an AIH-like injury after the COVID vaccine. So it had to have patients, in order to get into the study, no known pre-existing liver disease. Liver enzymes had to be fairly elevated at 5 times normal, and it had to be within 3 months of the COVID vaccine. So you can imagine there were tens of millions of patients in Europe at the time, hundreds of millions that were getting the COVID vaccine, and they were able to find 59 that had this sort of AIH-like liver injury. So it's extremely rare. Patients were treated with immunosuppression and generally did well. And this was another study, I think Craig may have been a part of this one too, looking at basically the same thing. And this corroborates what that last study showed. They were published around the same time, just showing that this was 87 cases, median 15 days after the vaccine. And there is this sort of immune features that we can see with, and if they had immune features on a liver biopsy, we treat with immunosuppression, and there's resolution afterwards. So I don't want you leaving saying that COVID vaccine causes AIH. It is one of the things, any drug, not any drug, there are certain drugs that can cause an AIH-like syndrome, and it's very rare. And I think that if you look at the numbers, the COVID vaccine is much less likely to do it than some of the other drugs that we already have out there. All right, so what should I do about the vaccine? And this was a paper published last year about what our recommendations are. So all patients with AIH should receive the vaccine. And suggested to have vaccine when the disease is under control. And there aren't, the biggest question I probably get asked is, if I have COVID, do I need to stop my immunosuppression? And the answer right now, there's no evidence to say that you should suspend or reduce immunosuppressive agents if you have a COVID infection. They talk about the risk of flare. There's no need to really test for antibodies. I don't think we're really doing that much anymore, but early on people were asking about that. If you have liver injury after the vaccine, we should just be careful with that and manage it according to guidelines. One of the publications I said, consider if you need another shot not to get that particular one, because it may not be vaccine, like a class, it may be just that one specific one that there's something in there that's causing it. Let's see, limited number of cases compared to vaccine subjects, and then if it looks like someone has a AIH-like reaction to a COVID vaccine, that's something that should be reported. All right, and the last sort of talk, hopefully you guys aren't falling asleep, no, it's early, is some of the research by the speakers here. So this is a paper that Craig and I collaborated on, and Kelsey was a part of this too. And so one of the questions that I see in my clinic a lot is, if you have AIH and you also have metabolic syndrome and the enzymes go up, is this steatotic liver disease or is this AIH? And it can be sometimes hard to determine which one is causing the enzyme elevations to go up. And so while it's not common to do serial biopsies, and I would recommend against it for patients with AIH, metabolic syndrome or steatotic liver disease is sort of part of metabolic syndrome. And so what we wanted to look at was what is the interaction between metabolic syndrome and autoimmune hepatitis? And do we see an increase in metabolic syndrome diseases? So what are those? Obesity, steatotic liver disease, elevated cholesterol, and diabetes are the things, and high blood pressure are the things that we looked out for. And because it's hard to diagnose steatotic liver disease without a biopsy, we just focused on the 4 that we could easily get through chart review. Going into this, we thought that really our hypothesis was that if someone was on steroids for a longer time, they were more likely to have these more likely to develop metabolic syndrome, because we know that steroids increase your risk for obesity, diabetes, and bone loss, as we heard about the excellent talk yesterday. And so we did a retrospective study looking at about 20 years of AIH. We had over 500 patients. I don't know how well this comes out. Yeah, that's okay. So what we found was over time, particularly high blood pressure sort of increases over time. But there wasn't anything that really jumped out at us as far as increases in the different aspects of metabolic syndrome. But when you look at it as a whole, what we found was that there were patients would gain, they were more likely to develop sort of one aspect of metabolic syndrome over time. So the number of patients that had none of these four diseases sort of went down over 3 years that we looked at. And then having one went up, more than one went up, and more than two went up as well. So we do think there's an interaction between sort of immunosuppressants overall and the risk of developing metabolic syndrome. Now, there are a lot of, and we went back and forth, Craig and I and Tess Bitterman, back and forth with the editors for a while to get published, because there were a lot of things about, some of the characteristics may not have been described well. But this is something that we're seeing. So it's you say, well, what should I do about this? It's more, you just have to watch out. If you find, when you're seeing your doctor, if you find your blood pressure is starting to go up or weight is going up, it's something that we need to work on to try to, or cholesterol is going up or development of diabetes, just to watch out for. AIH in gene expression, so this is Michelle's work at UCSF, and she talked to you guys about this yesterday, so I don't need to go in depth, and unfortunately my picture didn't show up well here. This is not what it's supposed to be. But they were able to see that there were certain classes of genes or RNA and proteins that were expressed in AIH more than not, and some that were downregulated. What about treatment withdrawal? So this is another big question. So people say, can I go off of my treatment? And the answer is, that depends. And this was, I don't know if Lindsay's here, if she left, but Lindsay wrote this review a few years ago looking at treatment withdrawal and looking at who could undergo treatment withdrawal when, what are the factors that are involved with risk of relapse if you do have treatment withdrawal. And so this is a really great figure, just showing these are the, if you have some of these, like if you have normal enzymes, if you've had a liver biopsy and it shows it's normal, and you've been on treatment for a long time and things have been normal, I think that the guidelines are it has to be at least 2 years of normal before you consider withdrawing. And then some other things, these are the things that would push us away from withdrawing treatment. So if it took a long time to achieve remission, or if there's still activity on the biopsy. And these factors didn't affect whether treatment withdrawal was a problem. Overlooked symptoms. So I wanted to, this is my last slide. And the reason, this is, I think a speaker yesterday on, the psychologist talked about this, but this is actually your research. So I wanted you guys to know, I think people glossed over this, but this, and some of you in here may have been part of these online focus groups. So just know that you are directly contributing to the research that is going on in autoimmune hepatitis right now. And this is, you can look online, and this is in PubMed. Whoever was part of this probably knows more about this study than I do, but there were 7 questions that were asked about how AIH impacts quality of life. And some of the responses, the big responses that were, there's a lot of fatigue, brain fog. Someone talked about brain fog yesterday, and my patients tell me that. Sleep disturbance, anxiety, and depression. And those sort of 5 aspects really affects work life, relationships, and leisure activities. And another thing that's disconcerting to me is that there are a lot of negative healthcare interactions, and so I'm hoping that I try to stay aware of that, but it's important for me to teach my fellow providers to really listen to your patients and really think about what the needs are. So this is the top of the paper. So I really think it's great that this is really, and this was patient-centered research. So I think this is, Craig asked, what are you interested in? And then this developed out of that. So thank you, if you have any questions.
What questions do we have for Dr. Weinberg?
Just curious if any statistics have been done regarding chances of siblings both having AIH or, close family members.
So there is research. It's prior to the past few years, but there is research showing that it's not necessarily AIH, but autoimmune diseases in general. So and Craig is more familiar with this research too. It's on, there's certain HLAs that can predict the development of autoimmune disease, but it doesn't predict specific autoimmune diseases. So when I speak with patients, I say, does anyone in your family have an autoimmune disease? And someone will say, oh yeah, mom had lupus, my sister has thyroid disease. So and how those end up manifesting can be different. But yeah, I'm not aware, I don't know, Craig, if you've seen a family history of AIH.
Yes, so at least from my knowledge in the past 3 years, I think there was a JHEP paper looking at AIH in families. It's really rare. That being said, I have 2 sister pairs, interestingly enough. So it happens. I think it's rare. But again, what Dr. Weinberg has said is this concurrent autoimmune disease is much more likely in first and actually even second degree relatives as well. So patients come in, do I need to screen my other child? I don't think it's necessary. It's definitely not in the guidelines, and I think the risk is just so inherently low.
I'm just curious, in all the research you did, I saw a lot around the COVID vaccine. What about if there was any research on patients who had had COVID and then subsequently had AIH versus the vaccine?
Yeah, so we have seen COVID itself can cause a cholestatic is the word we use, but it can cause jaundice that's different than the jaundice that we see with autoimmune hepatitis. But COVID itself can cause liver injury. And we're seeing that much more so early on in the pandemic and in patients that had very severe COVID. So if they were in the ICU on a ventilator, those patients were more likely to have this sort of horrendous cholestatic liver disease. And luckily I only saw one patient that had that, but that was also, in the right circumstances, we actually performed liver transplants in that.
Is there data on the severity of recurrent AIH after transplant?
There was some. It was pretty scant. The studies I was showing, they could only tell us sort of who was more likely to have it, but they weren't able to show that there was any difference in treatment and how to prevent it. What we do know is that, in general, for patients with AIH that undergo liver transplant, we tend to use a little bit more immunosuppression than for patients that, patients that have transplants for, say, alcohol or steatotic liver disease, we can usually wean down to just tacrolimus by itself, whereas for the autoimmune conditions, we'll tend to continue someone on 2 medications after a liver transplant. Not always, but that's the general rule of thumb. Now, just like relapse, we're not going to know, trying to get sort of the opposite of that. Like, can we withdraw treatment? And for liver transplants, for adults, it's exceedingly rare to withdraw treatment at all completely. But some of my AIH patients, I think maybe they are on TAC monotherapy, but that's over time. So it's a lot of trial and error, lowering doses, taking something off, and then getting labs very frequently. And some people can tolerate it and some not.
You did, just for point of clarification, you said to stay on steroids if you get COVID? Is that right?
Oh, don't change. It was
Don't
more like
change?
whatever
Okay.
you're on, just keep it the same.
Well, I'm just curious about why. And also just want to say quickly, like in April, I had bad liver function tests, like very high, 500, 300, and then had COVID in June. And then I saw finally got into the hepatologist in July And in July, my liver was normal. I'm like, nothing like COVID to clear out the immune system to stop attacking my liver. And then my liver enzymes went up again, and I had my liver biopsy and everything. But if I get COVID now and I'm on budesonide, I would feel weird about continuing the budesonide during having COVID. And I wanted to know, like, why would I want to keep suppressing my immune system if I have COVID? What is the thought behind that? Or is it just like you don't want to change anyone's therapies? I don't know. It's fair enough.
I'm concerned. What we're concerned about is we don't have enough data to say exactly what you should do, and so there's sort of a rule in medicine: if you don't know what to do, don't do anything. And so, so it's like you're on these medications. I don't know what to do. I would don't go up on them, don't go down on them, just stay the same, because it's more likely if we try to guess and play around with the medications, we'll cause more harm.
Sorry, one more question.
Sure.
When you mentioned the results around mycophenolate and, if I'm saying the right...
Azathioprine.
And azathioprine, is that impacting treatment plans going forward? Based
It
upon
may.
success
So
of
I still think, and this is going to be a big debate among physicians, is should this change first-line treatment? Now, I don't have the answer to that, because azathioprine, though it may not be able to cause remission at quite the same rates as mycophenolate, it still causes remission in a lot of patients, and the day-to-day side effects of azathioprine are less than what we get with mycophenolate. Mycophenolate can cause elevated blood pressure, it can cause nausea, abdominal pain, and it's a more potent immunosuppressant. And so if someone only needs a small amount, or even a moderate dose of azathioprine, and that's fine, that may be preferable to using mycophenolate in the long term. We don't know enough. It's just that study looked at short-term, sort of, can we get in remission? And so it's possible that maybe, and these studies are difficult to do in autoimmune hepatitis, and so we won't know like the answer of should you move from one to the other for a long time. But it's interesting to know that we can now use mycophenolate. It hadn't even, as I showed in that first slide, it hadn't even made it into like the preferred guidelines. And I think this is going to say, yeah, it's going to put it in there. And now if it makes it into the guidelines, then more doctors will feel comfortable using it. So most doctors who are not associated with liver transplant centers feel uncomfortable using mycophenolate right now. And so I'll often get patients referred to me because they failed azathioprine, whereas if they're on azathioprine in the community, people feel comfortable using that. So it'll change. I think it will actually help treatment better, because people will say, oh, this is the recommended therapy, we can start that, or even if you fail azathioprine, I feel comfortable changing to mycophenolate. All right, thanks very much, guys.